Welcome to our October seminar for the American Chemical Society's Greater Houston section. My name is Dawn Friesen. I am the 2021 chair of the section, and I have the pleasure today to introduce Dr. Roger Bertholf. Dr. Bertholf is a medical director of clinical chemistry at Houston Methodist Hospital and professor of clinical pathology and laboratory medicine at Weill Cornell Medical School. He received an MS in analytical chemistry and a PhD in biochemistry from the University of Virginia. And following fellowships in clinical chemistry and neuropathology research, he spent 30 years on the faculty of the University of Florida College of Medicine before moving to Houston in his present position in 2017. He is a diplomate of the American Board of Clinical Chemistry with certificates in clinical chemistry and toxicological chemistry, and is a fellow and past president of the Academy of the American Association of Clinical Chemistry. He is also a fellow and past president of the Association of Clinical Scientists, who turns up a lot when you Google search for ACS things, it turns out. Dr. Bertholf is editor-in-chief of Laboratory Medicine, a publication of the American Society for Clinical Pathology and Oxford University Press. He has been a member of the American Chemical Society since 1981. We are very pleased to have him with us here today. And I will ask that everyone please put yourself on mute while Dr. Bertholf is presenting. You can ask questions in the chat and we will have a Q&A after the presentation. Dr. Bertholf, I will turn the floor over to you.
Well, thank you very much for that kind introduction, Dawn. Let me go ahead and take care of the technical details and see if I can get my screen shared. Whoops, I hit the chat and said, excuse me. Let's see.
You're viewing your browser and your email, and there we go.
Are we good?
Yes.
Do you see my screen? Okay,
Yes.
Great. I trained during the period of time that I like to call, let me just start first by saying I really appreciate the opportunity to speak with this section of the American Chemical Society. As Dawn said, I've been a member since I was in graduate school. I haven't been an extremely active member because the clinical chemistry community has its own professional activities that keep me engaged quite a bit. But I do appreciate this opportunity to speak to what I consider my kin in other chemists. I trained in clinical chemistry during what I like to call the golden age of clinical pathology. And that would be mostly the late 1970s through the 1980s up until maybe the early 1990s, but probably not past 1990. And I call that the golden age for a couple of reasons. Number one, instruments that were highly automated first became widely available during that period of time. Automated instruments for clinical laboratories, and it really changed the way that we practiced clinical chemistry because we were able to offer so many more tests so much faster and using fewer technical personnel. So it really changed things. And I also call it the golden age for a mercenary reason in that it was a time when we were paid for every test that we did. So the more, the better. And so we looked for instruments that could crank out tests at a breakneck speed. And I've given you a couple of examples here of instruments that were game changers in clinical chemistry. The first on the top left is called a SMAC. It was made by the Technicon company in Teaneck, New Jersey. And it stood for Sequential Multi-Analyzer with Computer, SMAC. And I think it says something that in that period of time, computers were so new that this company felt compelled to remind you that this instrument also included a computer. This was a beast. It was able to crank out like 30 tests or more, depending on how you configured it on every single sample. And it gave rise to these huge panels of laboratory tests that became so common, a Chem 24 or a Chem 32 that included 32 different diagnostic tests. And I'll get back to that issue in just a little bit. The second instrument was a Beckman Astra. Astra stood for Automated Stat Routine Analyzer. It was made by the Beckman Company, named after Arnold O. Beckman, who was famous in chemistry circles. He was a chemical engineer for inventing the pH meter. And he started a company in California that made the Astra, and its claim to fame was it was very fast. That's why they called it a stat routine analyzer. And it only did 7 things though, and it gave rise to the term the Chem 7, which was used very widely up until about maybe 15 years ago, when we changed the way we grouped tests together. But it used a lot of electrochemical methods, which of course are very fast and use very little specimen. The instrument on the top right was made by the DuPont Chemical Company. It's called the ACA, stood for Automated Clinical Analyzer. And the innovation that it introduced was random access. With the Astra and with the SMAC, basically all the tests were done on every single sample. With the ACA, you could choose which tests you wanted to do on each individual sample. And that was important in the evolution of laboratories from doing more and more and more testing to selecting tests and making sure that only the medically relevant tests were done. On the bottom left is an instrument that was made by the Abbott Corporation. Abbott, of course, had its beginnings in pharmaceuticals, like many of the in vitro diagnostics companies do. But this was the first instrument that sort of revolutionized therapeutic drug monitoring. Before that time, therapeutic drug monitoring was not very widespread, and this was an automated instrument and used the technology that I'm sure you're familiar with, fluorescence polarization immunoassay. It quickly became a dinosaur, though, because it was a batch-loaded instrument. And so you basically loaded it up with whatever samples you had. You closed the door and ran all the samples. It took about a half an hour, and then you opened it up and loaded it up again. What we like in the lab is more of a continuous flow of analyses of samples in the lab. So this instrument was replaced by the Axum, which was made by the same company, that incorporated not only the fluorescence polarization to do the therapeutic drugs, but also their heterogeneous immunoassay technology that they called their microparticle enzyme immunoassay. And that was called the Axum, and it was random access and was very widely used. The one thing that all of these 5 instruments have in common is that the only place you would find them today would either be in a museum or in somebody's overflow stockpile, stock room where they put things that they can't get rid of. They're all obsolete. The instruments that we have today are combinations of many of these features, but are much more sophisticated, much more highly automated, and much more highly accurate than these. But there was one other thing that happened during this golden age of clinical pathology that is pretty much the topic of my talk today. And that is the notion of looking for soluble markers of cancer. Cancer, as any oncologist will tell you, is a disease that the key to treating it successfully is catching it early enough. Because once it progresses beyond a certain stage, it's very difficult to treat. It's beyond the point where surgical cures are reasonable. Chemotherapeutic agents are not quite as effective after it goes past a certain stage. So the key to cancer has always been catching it early. But the problem is that many cancers are asymptomatic. You don't know you have it until it's progressed beyond the point where it is easily treatable. So these soluble markers that we'll call tumor markers were the promise that maybe we can find chemicals that we can detect that can reveal the presence of a tumor before it becomes apparent due to the symptoms that it causes. And that was a very exciting possibility that we were finally going to have some success against cancer. I don't know whether you recall that Richard Nixon, when he was president, he declared, well, he didn't declare the Vietnam War. He certainly managed the war for a period of time, but he also declared war on drugs, and he declared war on cancer. Unfortunately for him, he failed at all 3 wars that he participated in. Cancer is the second leading cause of death in the United States. It causes about 600,000 deaths every year. The leading cause, of course, is heart disease, and heart disease causes about 650,000 deaths. So if you take cancer and heart disease together, they cause over 40% of all deaths in the United States in a normal year. And 2019 was a normal year. 2020 and 2021 were not normal years because the total number of deaths in the US, instead of being its normal 2.8, 2.9 million, jumped to about 3.2 to 3.3 million because of COVID. So the proportion of deaths due to cancer and heart disease was relatively lower. There were still as many deaths, but from those causes, but it was a lower percentage of the total because of the deaths due to COVID. If you compare cancer rates in men and women, it's interesting to me that the most common cancer in men is prostate. The most common cancer in women is breast. Women are a little bit luckier than men in this regard because women do not get prostate cancer. However, men can get breast cancer. It's rare, but men can get breast cancer, whereas women have no prostate, so they don't suffer ever from prostate cancer. But if you look at the overall rates of cancers, they're pretty much the same for men and women once you get past those two. Of course, women have uterine cancer and also ovarian cancer, which men don't have. But if you look at what causes the most deaths from cancer, lung cancer in both men and women causes the most cancer-related deaths, followed by prostate and breast in males and females, respectively. And then colon and rectum, pancreatic are 3 and 4 on both lists. But you can see lung cancer really dominates. And so prostate and breast, even though they're the most common cancers in males and females, they're nowhere near the most lethal cancers in terms of individual cases. There is good news and bad news on this graph. The bad news, I'll give you first, is the top part of the graph that shows that despite our war on cancer and all of the improvements we have made in detecting and treating cancer, the truth is that the rate of cancer has increased over the past 40 years from 1975 to 2016. Even though it went up and it's coming down, or it seems to be trending down, at least in males. And that's mainly due to lung cancer and cessation of and fewer males smoking. The incidence in females is creeping up. And if you compare the rates in 1975 to the rates today, in general, the rate of cancer is higher today than it was then. So that's a little discouraging. However, the good news is on the bottom part of the graph that shows that mortality from cancer has decreased. And I think there's a lot of reasons for that. One is that we are better at treating cancer. We have a lot more extensive armamentarium of chemotherapeutic agents now. We are better at detecting cancer earlier. Colon cancer screening through colonoscopies has become much more common. Breast self-examination has become more common. And we're going to talk a little bit more about prostate cancer in a minute. But I think it's interesting if you look at that top graph, something happened between 1990 and 1995, didn't it? A lot more men, almost twice as many male, well, not twice, but almost 200 more men per 100,000 population got cancer than they did before 1990. So something happened during that period of time, and we're going to find out what that was. It also is curious that it went back down. It didn't stay up, it went back down, but you can see that the increase in overall incidence, that little blip is all due to males. So if you want to know what caused that, we'll have to look at the individual cancers and see what were the cancers that caused that big spike in male cancer after 1990. Well, there's no mystery to it at all. It was all prostate cancer. So before this time, before 1990, the cases per 100,000 were about 125 or less, but then jumped up to almost 250, almost doubled the number of new cases of prostate cancer in that period of time. And if you're clever, and I'm sure you are, you probably realize what happened here. What happened was we found a marker for prostate cancer. So cancers that wouldn't have been diagnosed before because they were never suspected, prostate cancer is often asymptomatic. We were now detecting prostate cancer, so we had a spike in the number of cases because of the appearance of a marker, a biomarker for prostate cancer. Now, you might ask, why did it come back down? Well, overall, I think the explanation for this peak right here is the fact that when we first had the marker, the number of biopsies that were being done of prostates to try and diagnose cancer in men who had an elevated level of that marker shot through the roof. And pathologists were unused to looking at so many prostate biopsies, especially when they were from prostates that had early stages of cancer. So they weren't really accustomed to how to stage those and how to classify those in terms of whether or not the cancer is going to be aggressive or not. And so these represent, that spike right there represents almost certainly overcalls. Prostate cancer that was diagnosed that probably in retrospect and given today's criteria would not have been considered cancer. There are many different things that we use as tumor markers. I'll give you just a few examples. Things like proteins, thyroglobulin is a marker for thyroid cancer. Immunoglobulin G or IgG is a marker for, if it's a monoclonal, is a marker for multiple myeloma, a blood disease. Enzymes are often used as markers. Alkaline phosphatase is a marker for bone cancer and sometimes liver cancer. Prostate-specific antigen, which we're going to focus on later in this talk, is a marker for prostate cancer. There are hormones that are tumor markers. HCG is a marker for ovarian cancer. TSH, thyroid stimulating hormone or thyrotropin, and prolactin are both products of the pituitary gland and are markers of pituitary adenoma. Oncofetal antigens, there are some antigens that are expressed in fetal tissue, and we lose the ability to express these when we become, when we become adults. And but malignant processes often revert tissue back to fetal to expressing fetal antigens or acting as though they're still supposed to be growing as fetal cells often are. So alpha fetoprotein and carcinoembryonic antigen are two markers of typically, or CEA certainly for colon cancer, and AFP for a variety of cancers, including, I believe, liver. There's the carbohydrate antigens. You may have heard of CA125 and CA19-9. Those are also expressed by tumorous tissue. Sometimes we look for receptors. Estrogen and progesterone receptors plus the HER2/neu receptor are used to help determine what the best treatment for breast cancers might be. And oncogenes are genes that promote oncogenesis, but they're often suppressed. There are tumor suppressor genes that keep those oncogenes in check, but their overexpression can result in tumors. And there's also genetic markers for tumors. If we want to develop a new tumor marker, we really are looking for three things. One, we want something that's relatively easy to measure, something's economical, because if it can only be done in a research lab that's, in California, and it takes 2 weeks to get the result back, that's not really going to be a very useful test for monitoring or screening for cancer. So we want something that's relatively easy and economic to measure. We want something that's specific for the tumor. This is the hardest criteria to meet, because almost all of the tumor markers that we use are things that are normally present. In other words, they're not absent when there's no tumor and present when there's a tumor. They're simply there in a higher concentration in the presence of the tumor. And many times there are other processes, non-cancer processes, that can occur that can cause elevations in those markers, things like inflammation and hypertrophy. So getting a marker that's really specific for a particular tumor is difficult. It's a hard criteria to meet. The last criteria is that it's always present with the tumor. If we're going to use it as a marker, we don't want to miss tumors. So we want it to make sure that the tumor marker is going to be elevated whenever a tumor is present. And that expresses the sensitivity. So easy to measure, specific for the tumor, and sensitive for the presence of the tumor. Well, how, quickly to digress, there's a number of different ways that you can use tumor markers. The promise was screening for disease. Being able to detect asymptomatic cancers was what the real promise was, and what everyone was so excited over. Not to reveal the ending, but I think you already know what it is. What we're going to find is that they're not very efficient for that purpose, not very cost effective. You can use it to diagnose symptomatic patients. In a patient that you think may have the cancer based on their symptoms, the tumor marker might help you narrow down the diagnosis. Sometimes the tumor markers are proportional to the extent of the disease. So the higher the level of the tumor marker, the poorer the prognosis and the poorer the stage of the disease. They can be used to detect recurrence. If you treat a disease, for example, if you treat prostate cancer by removing the prostate by a radical prostatectomy, PSA should go to 0. If you then start to see PSA again after a period of a month or a year or 2 years, the reappearance of PSA is a bad prognostic sign, because it indicates that you didn't get all of the disease and it's begun to grow again. Finally, you can use them to monitor response to therapy, but that's not all that common. And I'm not really going to talk about radio immunolocalization right now, but I want to highlight this one because of all of these applications of tumor markers, it turns out this probably is the most effective way to apply and use tumor markers. And what I'm going to try to do by the end of this talk is convince you why the markers are not particularly useful for screening people for asymptomatic disease, which was what we really hoped they would be. How do we characterize the performance of a laboratory test? Now, I'm going to focus on tumor markers, but this concept is not unique to tumor markers. It's essentially applies to any laboratory test that is intended to detect the presence of a particular disease. In this case, the laboratory test will be the tumor marker and the disease will be cancer. But in both of those cases, what you're going to do is you're going to do a clinical trial where you you recruit a bunch of people who have no disease, perfectly healthy people, and by every diagnostic method that is available, you can confirm that they do not have cancer. And then you get a group that is confirmed to have that particular cancer that you're trying to detect. That's your positive group, and this is your control group. And you're going to measure your marker concentration in both of those groups. And typically what you'll get is something like this. You get a grouping of low concentrations in your control group, and you'll get a grouping of elevated concentrations in your group that has cancer. That is, if the marker is related at all to cancer and gets expressed in abnormal levels in the presence of a tumor, then you get data that looks like this. But because the marker occurs normally and can be elevated for reasons other than tumors, you're likely to get some overlap between your control group and your disease group. So the question is, where do you draw the line? Where do you establish a threshold above which you're going to say this person has cancer, or below which you say this person doesn't have cancer? Well, you might approach that and say, well, we don't want to miss anybody that has cancer. We want to make sure that if the test is positive, that if they have cancer, the test is going to be positive. So you could draw your threshold right here. And so anything above that's positive, and you can see all of the people who have the tumor are now positive. So your sensitivity, the sensitivity of this test is 100%. Let me just mention really quickly, it's unfortunate that we use the term sensitivity in this context, because I know to analytical chemists like us, sensitivity usually means something else. Sensitivity means the ability, what the smallest concentration or the smallest amount of an analyte that an analytical method can detect. And in a clinical sense, it means something slightly different, but we use the same term. And I know that you understand the difference, but sometimes that difference is difficult to explain to people who don't have a background in analytical chemistry. But we have sacrificed some specificity here, because there are going to be 4 people who test positive but are controls that don't have the disease. So the specificity of the test is going to be 81%, sensitivity 100%. Well, you might look at that and say, I want somebody who tests negative to be absolutely certain that they don't have the disease. I'm more interested in the specificity. So instead of drawing the line there, let's draw it there. Now, all of the controls are below your threshold for a positive result, but you have 4 false negatives among your cancer patients. So you have sacrificed some sensitivity, which is now 81%, to maximize your specificity, which is now 100%. So there's one other possibility. You could say, well, maybe those 2 extremes are neither one is reasonable. Why don't we just take the best compromise between the 2? So you could draw your threshold there. And now you've optimized both sensitivity and specificity at 95%, but you're still going to have some false positives and some false negatives. So this basically is the way we go about characterizing the clinical performance of a laboratory test. How many people does it classify correctly in terms of whether they have a disease or not? Well, there's a subtle problem with this approach that you may or may not have recognized. And it comes about when you consider how a test is going to be used in clinical practice. What I talked about so far in terms of sensitivity and specificity. Sensitivity we define as positivity in the presence of disease, and specificity is negativity in the absence of disease. But both of those merely tell you how well the test does when you already know whether the patient has the disease or not. In clinical practice, you don't know whether they have the disease. If you did, you wouldn't need to order the test. When you order a test on somebody in clinical practice, you're ordering it to try and determine whether or not they have the disease. And so what you're mostly interested in is, if the test is positive, what is the likelihood that the person actually has the disease? And that's not either sensitivity or specificity. That's something we call the predictive value. The predictive value is the true positive rate divided by the true positives plus the false positives. So it's the percent of all of the positive results of that test that correctly identifies someone who has the disease. So in clinical practice, that's what we actually are looking for, and what we actually use to determine whether or not someone has a disease based on the result of a test. Now, there's one other important difference between the predictive value and the sensitivity and specificity. Sensitivity and specificity, specificity are determined by how closely the thing that you're measuring is related to the progression of that disease. So if it's very highly related, your sensitivity and specificity are going to be high. If it's only sort of related, then they're not going to be so high, but they don't change. If you select a certain analyte and you do that kind of clinical trial on it, you get a sensitivity and specificity that is part of that test, no matter where it's applied. So those numbers are, to a greater or lesser extent, are written in stone. Predictive value, on the other hand, and this is what I'm going to try to convince you in the rest of this talk. Predictive value, on the other hand, is determined by what the prevalence is of the disease in the population that you're testing. You might look at it another way. It's determined by what the pretest probability is that that person actually has the disease. And the best way to illustrate that, I think, is through examples. And I'm going to give you a couple of examples, and I freely admit and disclose the first example is completely imaginary. I made it up, and I only did that because I think you'll see by the end of the example that I wanted to illustrate how even a very, very good tumor marker test can perform very, very poorly when it's used in a population that has a low prevalence of disease. So what we're going to do, you labored away in your lab for years and finally discovered a new marker for liver cancer. And you're very, very proud of this marker. And so you did your clinical trials and you found that it was positive in 98% or 98 of 100 patients that had confirmed liver cancer, confirmed by biopsy or whatever the most accurate method would be. So the sensitivity, obviously, of the test, the clinical sensitivity is 98%. If you have the cancer, if you have liver cancer, the chance that the test is going to be positive is 98%. So then you do the test in 100 people who have no evidence, no evidence of liver cancer at all. You've had every scan, every test that can be done, and they're all negative. And so your test is positive in 15 of those 100 patients that don't have any evidence of liver cancer. And this goes back to that problem that I mentioned where most tumor markers are present normally. And all you're really able to do is look to see whether the concentration is above what you would expect in someone who doesn't have cancer that is overproducing that particular marker. So I'm given a specificity of this test at 85%. Now I can tell you, I don't know if you ever look at these parameters with regard to clinical tests, but something with a sensitivity of particularly a tumor marker with a sensitivity of 98% and a specificity of 85% is a pretty doggone good tumor marker compared to just about all of the others that we have available. This would be a star. This would be one that everybody would want to use. So the next thing you're going to do is you're going to ask, how well does the test perform in the real world? And to do that, you're going to go down to the Galleria Mall, and you're going to set up your booth and put up a big sign and say a free screening for liver cancer. All we need is a drop of blood. And so you're going to stay set up there until, let's say you're going to stay there until about 100,000 people come by. Well, we know from population studies and epidemiological studies that liver cancer has an incidence of about 12 cases per 100,000 people. It's relatively low among cancers. It wasn't on the top 10 list that we looked at for either males or females in terms of the most common cancers. So it's relatively uncommon. It's depending on how you would define rare, I would say it's probably a pretty rare cancer. So if you wait at your booth until you've 3 or 4 months and finally you've had 100,000 people come by and give you a blood sample to run your test on, we can pretty well predict what's going to happen with your brand new test. Number one, in 100,000 people, there's likely to be 12 cases of liver cancer, right? Because that's the prevalence of the disease. Now, of those 12 cases, your test is almost certainly going to identify all of those, right? 98% sensitive. Now, maybe it'll miss one, but let's give it the benefit of the doubt. And let's say that the test is positive in all 12 of those cases of liver cancer. That leaves 99,988 subjects that don't have cancer, and the test is going to be positive in 15% of those, because remember, the specificity is 85%, so the false positive rate is 15%, or about 14,000 out of your cohort. So if we plug those numbers into our equation for the positive predictive value, true positives divided by true positives plus false positives gives us 12 true positives plus divided by 12 plus 14,000 false positives. And if you multiply that out by 100, that comes out to a positive predictive value of about 0.1%, which is to say only 1 out of every 1,000 positive tests that you get is a true positive, actually identifies somebody that has liver cancer. And this was a test that we had such high hopes for. That's why I contrived it the way I did. This would be a very, very highly sensitive, highly specific test. Good specificity anyway, but in a unselected population, in a random population, screening them for the presence of liver cancer, the test is pathetic, isn't it? I mean, only 1 out of 1,000 positive results is actually a case of liver cancer. So I know what you're thinking. Yeah, but you made that case up. You made that. That's just, you made it up so it would look really, really bad. And in a way, I did, but because I chose liver cancer, which is a fairly rare cancer. So let's look at a real world example. Just as an aside, you can also calculate the predictive value of a negative result, which is true negatives plus true negatives divided by true negatives plus false negatives. We didn't have any false negatives. We said the test was going to be positive in all the liver cancer cases. So the predictive value of a negative result is virtually 100%, which is not surprising and not really particularly helpful, is it? Because going in, the chance of having liver cancer was very, very remote, only 12 cases in 100,000. So you already knew your chance of having liver cancer was very low. Having a negative, you could argue that having a negative test result doesn't really add a lot to the knowledge that you already had. Okay, so I'll give you a real example. Prostate-specific antigen, I'm sure you have all heard of. It turns out to be a serine protease enzyme, 34 kilodalton. It's a member of the kallikrein family of enzymes. Its function physiologically is to liquefy semen and promote sperm motility in the ejaculate. But the nice thing about PSA is, and one of the things that makes it unique among tumor markers, it is absolutely specific for prostate tissue. It's not produced anywhere else in the male body and not produced anywhere in the female body. So the marker has the advantage of being specific in that it is only produced in the prostate. The drawback is that it is normally produced in the prostate. It's not just produced in prostate cancer, but it is elevated in prostate cancer most of the time. Just as sort of another note, it forms complexes with two proteins, alpha-1 anti-chymotrypsin and alpha-2 microglobulin. And we run into difficulties many times in the clinical lab trying to harmonize two different methods that are supposed to measure the same thing. And immunoassays to measure PSA have been very difficult to harmonize because they react variably with the two protein complexes of the enzyme. So most of them react to some extent with the ACT complex, but most of them don't react with the AMG. So there's biases between different methods based on that reactivity. All right, just a quick note about prostate cancer. We already pointed out that it is 28% of all cancers in men, the most common cancer in men, and the second leading cause of cancer death. Now, I won't go through the clinical studies that verified this, but we chose a cutoff, a threshold of 4, and anything over 4 we're going to say is an elevated PSA. Anything under 4 we're going to say is not an elevated PSA. And using that criteria, it has a 78% sensitivity for prostate cancer, but the specificity is only 33%. And the reason for that low specificity is that there are other things that can enlarge the prostate that are benign. They're non-cancerous, but they also produce elevations in PSA. It also has the advantages, the higher the PSA, typically the more extensive the cancer is, and it can be used to monitor therapy. But given those things, I chose PSA deliberately because among all tumor markers that we use in the lab, in a clinical lab, PSA is probably the most successful one. If you judge a tumor marker as how effective it's been at reducing deaths due to cancer. And you can see from this graph on the right that it used to be that about 1/3 of all men who were diagnosed with prostate cancer died within 5 years of their diagnosis. That has steadily improved up until that magic year, 1990, when it almost topped out at about 100%. And today, the 5-year survival for prostate cancer does very, very nearly approach 100%. So in terms of saving lives, PSA has probably saved more lives of men than any other tumor marker that's ever been proposed. So let's see how well it performs given the same kind of criteria that we did before if we screen 100,000 people. Well, the incidence of prostate cancer in men in general, in all men, everybody over 18, is about 165 cases per 100,000. So we can do our math and say that of those 165 in 100,000 men, our test is going to detect 129 of them because its sensitivity is 78%, and that's going to leave 36 false negatives. And if we calculate the true negatives, is 99,835 times 0.33, our specificity. So true negatives will be close to 33,000. False positives will be about 67,000. So let's plug those into our equation for predictive value. Now we have 129 true positives and 66,889 false positives. That gives us a predictive value of about 0.2%. That means in men in general, any randomly selected man who tests positive for PSA, there's only about a 1 in 500 chance that he actually has prostate cancer. Predictive value of a negative result is 100%. So you're saying, well, Roger, if it's that low, how can this be such a good tumor marker? Well, you might also have realized I tilted the table a little bit, didn't I? Because I said, we're going to test all men 18 and older. Well, prostate cancer almost never occurs in young men. It most rarely occurs in men that are under 40 years of age. So we're loading up our sample with people who are very, very unlikely to have prostate cancer. So that's why the low predictive value. So why don't we use a group that is more pertinent toward trying to determine whether they have cancer or not, because, you know, to a 22-year-old, they don't care whether they have prostate cancer because their chances of it are minuscule to start out with. But once men reach the age of about 40, the period between 40 and 60 is really pretty important because many prostate cancers are very slow growing. And a man between 40 and 60 probably has 20, 30, maybe 40 years of life left. And even if you have a slow growing cancer, chances are it's going to develop into something that is going to cause you trouble before anything else might take your life. So it's really important to identify early prostate cancers in that group. So we can't change our sensitivity and specificity, but in men 40 to 60, the incidence of prostate cancer is about 3.5%. So we can go through our math again, and I won't bore you with going through all these again, but we'll have 3,500 cases, 2,730 true positives, 64,655 false positives. So we plug those into our equation, and now the predictive value of a positive result turns out to be 4.1%. So now 1 in about every 25 or so positive results is a man that actually has prostate cancer, and that may be something worth pursuing. If you have a 1 in 25 chance of having a cancer based on the result of a test, then that's something that you probably would want to follow up with additional testing, or at least do the PSA again the next year to see whether it's increased or not. So now it's starting to become a useful test. Finally, let's look at the group that has highest incidence of prostate cancer, men that are over 60 years old, a group that unfortunately includes me. And with the same sensitivity and specificity now, we have an incidence of 14% of men over 60 years old have prostate cancer. So we screen our men. I won't go through the math again with you. You know how it works by now. Almost 11,000 true positives, about 58,000 false positives. Plug those into our equation. Now we have a positive predictive value of about 16%. That means 1 in about every 6 men who test positive actually has prostate cancer. So that's when it becomes a very useful test. If you have a 1 in 6 chance of having prostate cancer, then obviously it's something you're going to want to talk to your doctor about and follow up on and firm up the diagnosis, possibly with a biopsy to confirm whether or not you have cancer. You might also notice that because the sensitivity of the test is not 100%, we're always going to have some false negatives. And the more positives you have, the more false negatives you're also going to have. And so your predictive value of a negative test goes down as well. In this case, if you have a negative test, there's still about a 10% chance that you might have prostate cancer. So the last thing that I'll talk about is, what do you do about a test like this? Can we do anything to improve it? And it turns out sometimes we do have options to improve a test. What we've talked about so far is just measuring the total PSA. And you remember I said that PSA occurs in more than one form. It occurs in the free form, and it occurs complex to two other large proteins. Maybe it binds to those proteins differently if you have cancer than if you just have an elevation due to benign prostatic hypertrophy or a benign process that causes enlargement of the prostate. And we know all about that because you see the Flomax commercials on TV all the time about trying to reduce benign swelling or benign enlargement of the prostate gland. So it turns out that if we measure the free PSA and take that as a ratio to the total PSA, as long as the total is between 4 and 10, and I won't go into detail as to why we limit it to that range, but it's because that's the only range in which it's really useful. Now we have a test, the free PSA to total ratio, that has a sensitivity of 95%, but the specificity is only 20%. So let's take that group of men that are over 60 years old that have an incidence of 16% of prostate cancer and look at what their total or free PSA to total PSA ratios are. We can do the calculations based on sensitivity and specificity, and now we get a positive predictive value of about 18%, up from 16%, but now we're down to about 1 in 5 men who test positive actually have prostate cancer. But the predictive value of a negative test, because we have now fewer false negatives because our test is more sensitive, we have a little better predictive value of a negative test. So let me just summarize the lessons that we learned about predictive value. First of all, and I did this with, I think, a contrived example, but I think it illustrates it pretty clearly. Even when you have a very good test, a very good tumor marker, it's generally not effective to screen for a tumor or any other disease in a population that has a very low incidence of that disease, or screen people who have a very low pretest probability of having that disease. A caveat that I would give is, if you have a confirmatory test that is available and is cheap and can be done very easily, then the screening test might make sense, even though it has a low predictive value. I'll use the example there of something you probably are familiar with. What do we use to screen for diabetes? You go to a health fair somewhere, they do your blood sugar. You may not have been fasting or anything, so your blood sugar might be high or it might be normal. If it's normal, that probably means you're not diabetic. If it's high, it doesn't mean you're diabetic, because it could have been you had a carbohydrate meal recently or had a sugary snack or something like that. So, but you can always confirm with widely available and relatively economical follow-up tests that are much more specific for diabetes. So sometimes screening in a general population, in an unselected population, makes sense. But if we've got a test that has the kind of predictive value that PSA has, or really other tests that have fairly low predictive value, the way that you can improve the performance of the test is to limit its use to people who already are likely to have the disease. Now, that might sound kind of counterproductive. If they're so likely to have the disease, do you really need to run the test? Well, I think that's a valid question. But the truth is, since clinical suspicion and pretest probability are exactly the same thing as increasing the prevalence of disease in a given patient, in a given subject, then what you've done is you have improved the predictive value of a positive result by selecting a patient that has a higher probability of having the disease in the first place. So in this way, clinicians really, they control the value of laboratory results by selecting patients that are likely to have the disease and testing them rather than testing patients indiscriminately, thinking the test is going to give them information that is valuable. When in fact, as we've seen, the test may give them information that is in fact of very low value. So let me just finish up by showing you a nice picture of the hospital where I work. It's Houston Methodist Hospital in the Texas Medical Center. This is the main building, and there's actually 7 buildings in the Texas that belong to Houston Methodist in the Texas Medical Center. It's the largest of the hospitals in the Texas Medical Center and has about 1,000 beds. But that's not our only hospital. We actually have 6 other hospitals in the community. We have a 248-bed hospital in Baytown, a 321-bed hospital in Sugar Land, 200 beds in West, 312 in Willowbrook. We have the Clear Lake Hospital, and we have a hospital in Woodlands. And if you were to plot these on a map of Houston, you would see that we're like the hub in downtown Houston, or at least downtown in the medical center. And these are almost evenly spaced around the periphery of Houston. So Houston, medical care-wise, we've got you covered. And I appreciate the opportunity to talk to you, and I appreciate your time tonight. And I'll be happy to answer any questions if you have them.